Hi everyone, thank you for joining us today. Today's tutorial is on schizophrenia and psychosis given by Dr. Dalton. Just a couple of rules if you're watching on the Zoom. If you have any questions that are relevant to what's being covered in the tutorial in the moment, just pop it into the chat. If you have any questions that could perhaps wait till the end, then just pop it into the Q&A. If you're watching via the Facebook live stream, then just comment your questions and we'll make sure that Dr. Dalton will get this. That's all from me, and I'll hand over to Dr. Dalton right now. Thank you.
Lovely. Yeah, thank you very much, Anil. So yeah, my name's Tom Dalton. I'm a core trainee in psychiatry. Delighted to be here giving a lecture for you guys. As you can see, I was torn between the standard teaching from home backgrounds of books or art, so I have gone with both so that you may know that I'm both classy and an intellectual. But yeah, I hope you enjoy this evening's tutorial. As we said, it's sort of an introduction to psychosis and schizophrenia. So I'll fire up my slides in just a second. Said, please ask any questions as we go along. And I'm more than happy if you think of questions afterwards, maybe if you get in touch with the Becoming a Doctor team, for them to pass on questions to me, or if you have any other questions about psychiatry in general and psychiatry training. All I'll say on that front is I really love my job. I'm having the best time doing core psychiatry training, and I will talk to you for as long as you like about doing that and how to get there and the benefits thereof, but not tonight. So let's crack on. Oh, hang on, if I can just remember how to operate basic computers. Sorry, that's the wrong button. Right, okay, I am competent, I promise. There we go. So, the title of my talk is Madness, an Introduction to Psychosis and Schizophrenia, because I suppose we're starting from the point of view of really trying to grapple with what those terms mean and how they relate to sort of the popular conception of madness. But you know, it's all med student stuff that you need to know for exams. I'm not going to, yeah, it just makes it a bit fun. So a quick disclaimer to start with from the Becoming a Doctor team, just to say that these are my opinions, doesn't necessarily represent them. So bear those in mind. While you have a quick look at that, there's a quick question on the chat, which I will just make sure is nothing horribly urgent. No, the chat's not. Okay, I'll come back to that in a bit. Anyway, on we go. So, these are our learning objectives for this evening. So, fairly basic introductory stuff. The only thing I'll say is there's a fair lot to cover here. So I'm going to be very brief on the treatment for psychosis. There's a lot more that I think you guys will need to know in terms of specifics about medications that I'm not going to cover tonight, just because it was a bit too much to pack in. But just bear in mind, I'm going to be quite brief on that. But hopefully the other stuff should be covered in enough depth for you to feel comfortable with it. So, just taking a step back, looking at mental illness, patients with psychiatric complaints in general. You probably have learnt about or seen, whatever, people with, you know, common disorders such as anxiety or depression or eating disorders, which I suppose they all fall into a similar camp in a sort of way, because although maybe very hard to imagine what it's like to experience them, we can sort of talk to these people about their experiences of living with that, and they can describe it, and we can make sense of it perhaps relatively easily, sort of based on them describing their sort of conditions. And also, I suppose, the representation of these disorders in the media and the particular kinds of stigma that they may be subject to is of a camp. But then you have another kind of patient. For instance, a young woman I saw over the weekend who was brought in under a section of the Mental Health Act because she jumped into the Thames and tried to swim across, and then was behaving very chaotically and bizarrely. It was very clear she wasn't well. It turned out over the last few weeks she'd been saying increasingly odd things to her parents over the phone. She's a young woman who grew up in Switzerland, but was working here as an au pair, and the lockdown had been really hard for her, obviously, especially with parents in another country, and various other stresses had occurred over the last few weeks. And then she really started to behave and say quite odd things. She was talking about neighbours were in the neighbourhood kind of talking to her when she couldn't possibly have hearing that because she was just in her room. And then when she came into the hospital, things really seemed to have escalated. She was behaving very bizarrely. It was impossible to get a sense of really what she was thinking. She was just talking constantly. Various very odd ideas like that she is God, or that she has a really important task to fulfill. We have to let her go because she must, and it was all to do with the pandemic and all sorts of things. So that's quite odd. It's quite a different, perhaps, to these other conditions. And maybe we have a kind of a different box that we might put people such as this in, rightly or wrongly. Because I think this group of these sort of psychotic conditions, if you like, where you have someone presenting as essentially as mad, insane, whatever you might call it in a non-psychiatric sort of context, we can find that quite frightening. Certainly it's much easier to imagine relating to that person than it is to just someone who's experiencing really, really bad anxiety. It's very hard, you know, and that there's sort of a fear in that complete unknownness. So let's try and get to the bottom of this box and what it really means in this type of patient. So, things that can make you behave in very bizarre and chaotic ways. There are a lot of them in medicine. So psychosis is what we're going to be talking about today. But there's also delirium, of course, which I gather you've had a recent tutorial on, or I'm sure you will if you haven't. So you know about that, but that can again make people say and do odd things, behave chaotically, and there's this all of those features of delirium. But then also other things, acquired brain injury, encephalopathy, various stuff can make people just seem to be on a completely different page to you and be mad, if you like. I'll just keep using the word mad because you can understand what I mean by it as we go along. Dementia as well, equally. Personality disorder, a very interesting topic, which I would hopefully maybe I'll volunteer to teach you on that a bit later. Again, you can have odd things that look a bit like psychosis within that group of diagnoses. And then in terms of the causes of all these things, so schizophrenia, the big cause of the big sort of things related to psychosis. We'll explore that today. But there are other things as well, other mental illnesses that that have psychosis as a feature, if you like. And then there are various things that can cause either psychosis or delirium, sort of medical causes, if you like, organic causes, that you'll probably be vaguely familiar with. And I mean, in reality, you don't see many of these very often, except for it's more common to see psychosis that's related to drugs. We'll talk about that later. But yeah, here's a general picture of all the things that can make you appear mad, as it were. So, let's have a quick look at psychosis, what it means, how can we understand it, how can we approach it. So, the definition, if you like, of psychosis, and it's quite hard to find a really neat, solid definition. But in general, it's defined as having hallucinations and delusions. Now, these are hallucinations is a percept without a stimulus, so basically you perceive something that isn't there. And I'm sure you know that. Delusions, we'll define that closely later on, but it's a bizarre belief that seems to have come out of nowhere. However, this might seem like quite a neat little definition that makes perfect sense. Hallucinations, delusions, done, that's psychosis. But in reality, if you really think about what is the brain for, like what are some of its fundamental jobs that the brain does? It perceives, it takes all the sensory information that's fed into it 24/7, and it filters it all and perceives it and assembles it into a kind of a coherent view of reality, kind of interprets it all. And that's kind of one of the main basic functions of a central nervous system. And if you really look at these, actually failing to perceive reality accurately and failing to interpret it accurately, that's actually quite a broad swathe of things that have gone wrong here. This isn't such a neat little defined disorder. And I liken it quite a lot to, I don't know if any of you doing medical attachments, you've probably seen in the A&E notes, the diagnosis off legs. And this is a sort of what people might write on the clerking, if there are initial clerking where an elderly person comes in and they can't walk. And this could be due to many things. They could have broken their hip, they could have delirium, they could have an infection, they could have all sorts of stuff. But the end result of all of those different disease processes looks broadly the same, that they can't walk. And psychosis is very similar to that, really, that it's kind of a similar common result of lots of different disease processes, where the end result is you essentially, instead of losing the ability to walk, you kind of lose a grip of reality. And so one way to think of it, and this is just a way I like to define it, is as reality failure, in the same sense that you get kidney failure and heart failure. There's an organ system that is not functioning as it should do normally, to the point where, it has a series of sequelae. And this kind of fits in with a lot about how we think of psychosis. Firstly, that has various causes, similar to, I don't know, heart failure could be caused by various different things. And there are all of these different features, which we will look at in a bit more detail as we go along, which are kind of all related to the processes, the normal processes of perceiving and interpreting reality, but something's gone wrong there. You kind of lose this grip of reality overall. But just like in heart failure, whether it's caused by emboli or caused by myocarditis, or whatever it may be, the end result is, I don't know, sort of a congestive cardiac failure picture. It all looks quite the same. Similarly, psychosis will often look quite the same no matter what has caused it. And one feature that distinguishes it from delirium is you have this quite clear consciousness. They're not fading in and out of consciousness, and they don't often, their intellect is fine. It's just they are deluded, hallucinating. So there we go. Now, before we go on with more kind of clinical definitions and things, I thought it'd be worth just having a quick think about reality normally. I'm aware that's quite a big topic, but I will be brief. But it's just a few important points I want to highlight. Because I think we know that we all have a brain, but actually if we don't interrogate our preconceptions too carefully, we can sort of fall into the trap of assuming that the perception of reality is a bit like this. Not really that there isn't a guy sitting in our chair, head on chair, but that the whole of reality as it truly is, a realistic portrayal of everything that is around us, just arrives unproblematically to our consciousness. And there's, that just happens and it's all fine. But in reality, we know that isn't true. It's much more complicated than that. The whole of reality around us is just converted into code as soon as it hits our retinas or our eardrums or whatever it may be. Sorry, not cochlea, whatever. And is somehow assembled into what we perceive to be a coherent model of everything that's around us. But, it's not a completely straightforward process. It's an immensely complicated process. That's made up of hundreds of millions of tiny other smaller processes. It's just, so don't fall into the trap of just assuming that it kind of happens straightforwardly. And a couple of little things I just want to draw out of this brief point is firstly that consciousness, we can kind of assume that's just a thing, consciousness, and it exists, and there it is. But it's probably not really like that. It's more kind of modular, made up of lots of other different processes that eventually produce what we perceive as our consciousness that seems to be either there or isn't there. These sort of parallel processes running at the same time. And also that, and this is just relevant, I suppose, to some of the disease processes we'll talk about, the things we are consciously aware of are selected by attention. And that's not just choosing to pay attention to things, like I hope most of you are choosing to pay attention to this talk, but also just passive attention, the automatic filtering out of unnecessary information, so that our attention is only drawn to stuff that is salient to us, that is important to our survival, basically. And it's become salience is a very important concept that we'll come back to when we talk about the disease process of psychosis and schizophrenia. So on we go, but a quick kind of reality check first. Have a look at this picture and see if you can tell what it is. It's a photograph that's been turned into black and white. You shouldn't be able to tell what it is. I'm just going to put that out there. It's very difficult. But here we go. It's a baby reaching for a piece of a puzzle. So look at that for a moment. Just take in the baby. Now back we go to the photograph. And you can still see the baby, can't you? You can still see, that's the baby's cheek, that's the baby's hand. And the picture suddenly makes sense. Now, I promise you, I haven't changed the picture to what you saw before. You're perceiving the same sensory information is arriving into your brain as it was before, but it is modified somehow. Your expectations of it, your previous model, the things you've seen, whatever, are modifying what you see so that now you see a baby. The picture makes sense in a way that it didn't before. So that's interesting, isn't it? And here's a little optical illusion that I'm sure you're very familiar with. Oh, look, the squares are actually the same color, even though they look different colors. The point I'm trying to make here is that the sensory input we perceive is modified a lot pre-consciously before we're even aware of it to kind of fit our expectations, our pre-existing models about how the world is, all sorts of things. So I guess this is a useful thing to kind of bear in mind when we talk about psychosis, that everyone's normal perception of reality isn't flawless. It's not unproblematic. There's so much going on behind the scenes that actually, if you have the right clever little optical trick, you can have a window into some of the things that, you know, could go wrong potentially. I mean, the two pictures I've shown aren't really much to do with psychosis, but just to get the idea, there's a lot going on behind the scenes. So let's move on and look at some actual psychotic symptoms, shall we? So, as you might be aware, the most common hallucination in psychosis is auditory verbal hallucinations, hearing voices. You're kind of probably familiar with that stereotype. And, oh, no. What don't you get? Oh, anyway, if you can phrase more specifically what sorry, I'm just responding to a question in the chat. Yes, please ask questions as you go along and I'll pick them up. So, auditory verbal hallucinations, this is hearing voices, and it's, if you think about what that is, it's a classic symptom of being mad, I guess, you know, in popular conception, but it's where your own thoughts, which if you think about it, your internal monologue is a voice generally, but it's, you know it's an imagined voice, it's just your thoughts, but they come in words. Words are packets of meaning, they're like the fundamental unit of making sense of the world, if you like. So it makes sense, our thoughts come in words. But in auditory verbal hallucinations, essentially what's gone wrong is those feel as if they're coming from outside. Because actually, if you imagine someone speaking, a lot of the same things are happening in your auditory cortex to if you are actually hearing someone speak. And it's not a massive leap. I mean, it's, you know, a big enough leap that it doesn't happen to most people. There's not a massive leap for that you to have a failure in the monitoring of where that's coming from and experience your own internal monologue or an internal monologue as coming from outside, as a real sound that you can hear. So that's what auditory verbal hallucinations essentially are. They're experienced as external. And they don't necessarily mean that you have psychosis. So they're experienced by about 5% of the healthy population. They happen sometimes. It's not a massive deal. They're an antecedent, or sort of a feature of clinical disorders if they're combined with all of the other things that kind of go into creating psychosis, schizophrenia, all of the distress very often associated with them, the persistence, the real intrusiveness, and also the whole functional picture of psychosis where everything seems to go wrong a bit. That's when they're part of an illness, but on their own, they're not necessarily. So it's useful to know. Delusions, the next thing that I listed as a feature of psychosis. So this is the definition that you need to know for med school, basically. It's a good definition. It's fixed, false, unshakable belief out of context with their cultural background. And it's very interesting if you want to really debate about, you know, what constitutes a delusion. Because, so fundamentally, the classic one, someone who suddenly believes that their neighbours are trying to poison them, or that someone is trying to harm them, that's like a classic delusion. And that, the thing that makes a delusion, I suppose, is partly that it's come out of nowhere. There's no real evidence for that belief. They've just suddenly, within a matter of weeks, they're so convinced, and it's fixed and it's unshakable. They all of a sudden have this absolutely monolithic, unshakable conviction that this is true. And you can argue whatever you like into why it may not be true, and won't touch it. You can't reason with disbelief. But actually, that's, many beliefs that we hold are like that. Political beliefs, religious beliefs. You can't really reason, I mean, maybe they can, hopefully, if you're a reasonable person. So a key feature of delusions is that it's false and it's out of context with their cultural background. And again, this is where the debate comes in, because someone who believes in God, I mean, I'm a Christian myself, for instance, some people would argue that's a delusion. I mean, in psychiatric terms, you need to know it's not a delusion technically, because it's out of it's in the context of my cultural background. Lots of people around me believe that. That belief has developed through the normal process of developing a belief, whereas delusions kind of pop out of nowhere. The falseness is a tricky one, because sometimes people develop delusions, but actually there's an element of truth in them somewhere, and it gets very tricky. So I guess be aware of that. I would love to spend ages talking about the debates around delusions. It's very interesting, but I'll get on for the sake of time, and I'll quickly look at a couple of questions on the chat. Oh, so you don't get the optical illusion yourselves. Oh. No worries. Yes, there will be short answer questions as we go along. Sorry, they're about a few a bit later on, don't worry. Okay, so going back, in terms of making sense of why delusions happen. So, I said they sort of pop out of nowhere. That's not quite accurate, because often in psychosis, what you have before the delusion forms is you have a period of time where the person has this real, I've got a whole slide on it later, but they feel very perplexed, but there's this general sense that something strange is happening and they can't make sense of it. And that seems to be there first, and then the delusion crystallizes out of that after a period of time. And actually, maybe the delusion isn't the primary disease process. The primary disease process is this perplexity, and then the delusion is an adaptive response, the brain trying to make sense of that, and it develops the delusion. And this is an interesting theory. So a shear pin, this is just a wonderful phrase I encountered to describe delusions. A shear pin is a part of a mechanism that's designed to break deliberately if the mechanism is put under enough stress, and it prevents the whole machine from breaking. So doxastic is to do with beliefs. So essentially a delusion, the brain is almost, you can argue, is designed to develop delusions if the whole system is under massive pressure and basically can't function, because that's what happens really if you're really perplexed. And if you can carry on functioning, believing something a bit wacky about the world, but actually that's better than being paralyzed by this perplexity where you just are so uncertain about everything. Is an interesting theory. But yeah, it's interesting to look at where the delusion is. Why has this person developed this delusion at this time? Because often, I've talked about people believing that people are trying to harm them. And not uncommonly, you might see a background of childhood adversity, perhaps abuse in that person's early life. And there will have been these experiences of being harmed, of being threatened, of being at risk of being, and that experience is kind of sunk in and maybe resurfaced later in life. And I mean, it's not always as clear-cut as that. Plenty of times you'll see delusions that don't appear to have an obvious route that you can see in that person's experience, but they do sometimes, and it's interesting to try and look into that. And it's, I guess, important to really try and explore the person's story instead of just being like, they're deluded, good, psychosis, bye. Okay, and then yeah, as I keep alluding to, they're often persecutory. They're often about, I'm being harmed. And why is this? Well, it kind of makes sense. As we talked about, this might be a sort of a semi-adaptive response that the brain has to try and keep on functioning. If you are in a very uncertain, potentially threatening situation, defaulting to I am at risk is a good strategy in a way, because actually, if you're not at risk, then it's fine. You will have been hypervigilant for no reason. But if you actually were in danger, and that's why you felt uncertain, then you've taken precautions against it. So defaulting to a persecutory delusion in the face of this paralyzing general sense of something must be wrong it kind of makes sense in evolutionary terms, if you like. So some interesting thoughts about delusions that help give it a bit more context, I think. But ultimately for med school, this is what you need to know, if I'm honest. Yeah, right. So here's a quick poll, and I will now open this poll. So please respond to the poll, if you wouldn't mind. Hopefully you can all see it. Okay, I've got one response already. I'm just going to have a bit of water, I'm sure. Okay, got the last 10 responses. If you could quickly drop them in so we can see what people wrote and move along. I've got 5 people who haven't responded. I'll give you just 5 more seconds if you can make a snap decision. I'm sure maybe not everyone has it. Okay, I've got nearly 30 people, so I'll end it there if that's okay. Right, share results. Okay, so the correct answer, hopefully you can all see this, is that they're explicable in the context of cultural background. I.e., these questions are a bit annoying because it's a double negative, it's a negative question. But yeah, people have suggested they might not be unshakable, they're false, or frequently persecutory. They are all of those things. So yes, but most of you got the correct answer, that they are not explicable in the context of the cultural background. They popped out of nowhere, and you can't just explain them as in it makes sense that this person believes this because of how they've grown up, if you see what I mean. So that was very useful. Right. There we go. So now we're going to talk about schizophrenia. I'll just quickly check the chat for any, if Zoom will let me. Okay, Zoom isn't letting me check in the chat for now, I'm sorry. I will have a look in a second, unless, where is it? No, okay, I'll check it later. Schizophrenia is essentially chronic psychosis. That's probably the easiest way to understand it. We all are familiar with this disease entity called schizophrenia. And psychosis is obviously a massive part of it. And it's basically someone who has a first episode of psychosis, as you call it, and then actually, for whatever reason, has more episodes, carries on, and maybe has a global baseline reduction in their functioning, and has a chronic illness that has psychosis features. But there's a bit more to it than just chronic psychosis. And this is the title of a webinar I attended a while ago, even before webinars were cool in this pandemic time. But they're asking the question, these are some of the top schizophrenia researchers in the country. If you ever get a chance to see Robin Murray talk, he's so much fun. Anyway, is schizophrenia dead yet? They're challenging the idea of schizophrenia because in many ways there are some problems with it. It's a very large umbrella that actually includes so many different, probably different disease processes, different presentations, that is it still helpful to just label it all as schizophrenia? And people are asking that question. There's no particular answer to it. But for the time being, learn about schizophrenia. This is the construct we have. Maybe we'll improve it in your lifetimes. So, the symptoms of schizophrenia, I'm going to whiz through these, but these are things you need to know for med school. So, firstly, you have the positive symptoms, so-called because they add something to the person's experience. And these are hallucinations and delusions that we talked about. And very often, these are persecutory illusions, but they can be grandiose delusions, like my person that I mentioned, the woman who jumped into the River Thames. At one point she was talking about that she was God. I think I said that. So yeah, that's a grandiose delusion. You can't get much more grandiose than that. Where do you go from there? Yes, and then delusional perceptions. This is where you perceive something. It's a real thing that you see, but it has this delusional meaning that suddenly comes to you. So you see a black car pull up outside, and you know that that means the FBI have arrived to take you away. It didn't make sense before, but now that means the FBI are there. So that's what a delusional perception is. Don't know why I picked the FBI, we're in the UK. Anyway, delusions of control. This is believing that part of you in some way, your thoughts, your actions, your movements are being controlled by someone else. And thought delusions are delusions about thoughts. So the belief that I've just had a thought, but I believe that thought has come from somewhere else. Or my train of thought has just stopped and I believe that my thought has been taken out of my head by someone else. Or I believe that other people can hear my thoughts or read my thoughts. Those are all thought delusions, and they're very interesting and they're very classic of schizophrenia. So there's the positive symptoms. We also have the negative symptoms, so-called because they subtract something from the person's experience. You have lack of pleasure in anything, so it looks quite similar to depression in many ways. Complete well, not complete necessarily, lack of motivation to do anything. A real withdrawal from social, kind of a preoccupation with maybe delusory things, but withdrawing from social contact. Often you see poor self-care. Someone's just gone up to their room and stays there and isn't eating, isn't washing them, all of these things. And blunted mood, there almost seems this lack of reactivity in terms of mood to the world around them. Just what we might call a very flat affect is the kind of technical term. And then the disorganized symptoms, and these sort of particularly thought disorder goes a bit with the positive symptoms maybe, but these are disorganization in the functioning of normal thought essentially and emotion. So formal thought disorder isn't thought disorder in a suit and tie. It's where the form of your thoughts. So it's not about the content, what you're thinking, that's a delusion. Formal thought disorder is your thoughts are just jumping from one topic to the next, and the flow of thoughts is kind of disrupted. Or you're thinking about something and then just stops. That we call thought blocking. Or also, it can look in all sorts of different ways. And I won't go into detail today, but I can do potentially in a future session about kind of the different types of formal thought disorder, but you do need to know about those. And then disorganized speech and behavior, kind of a manifestation of formal thought, I guess, that the things they're saying and the way they're behaving is chaotic and makes no sense. And then inappropriate affect, so affect being kind of the current presentation of your mood is incongruous with what's actually happening. So you hear something sad and you laugh, or whatever it may be, can be a feature of that. So these are basically all the symptoms of schizophrenia. But it's tricky to define. So, I mean, someone can have just these ones and have schizophrenia, or they can have almost just these ones and have schizophrenia, or they can have just these ones, or yeah, you can have loads of people with schizophrenia who don't have any symptoms in common and all have schizophrenia, and this is why it's a tricky disease concept. There's a lot to say about, you know, there's these different subtypes of schizophrenia and what they mean and the neurobiology of them, which I won't cover today because there's not time, but it's an interesting topic. Cool. So moving on. Schneider's first rank symptoms, another thing that you sort of have to know from med school, and they were initially thought to be pathognomonic of schizophrenia. If you have these, you definitely have schizophrenia, and that's not quite true, but they're still pretty good, actually. If you see any of these symptoms, you can think, this may well be schizophrenia, not just a drug-induced psychosis or some other kind of psychosis. And these are, so as we said, auditory verbal hallucinations, particularly third-person ones, like you hear someone talking about what you're doing in the third person. He's doing this now. Now he's gesticulating with his hand. Now he's looking behind him at the piece of art, whatever. Delusions of thought control, we've kind of talked about those, is another really key feature of schizophrenia. And so thought insertion, someone's put a thought in my head. Withdrawal, someone's taken a thought out of my head. Broadcasting, other people can hear my thoughts are being transmitted on the television, for instance, and other people can hear them. Passivity phenomena, this is the delusions of control. So passivity, I am passive in my own bodily movements. My arm just moved, but actually I didn't do that. Someone else controlled that arm. That's what a passivity phenomena is. But it can also be, I just felt something, but it wasn't me perceiving it. It all gets a bit confusing, but this is passivity phenomena. And lastly, delusional perceptions, which we talked about. So these are Schneider's first rank. There are kind of, it's not just four, they sort of list all these different types, but these are the main ones that you need to know about. They come up in MCQs because they're quite easy MCQ fodder, but they're not kind of used that much diagnostically anymore. Yeah, there we go. And then if you dig even deeper under the surface of really what is going on in schizophrenia, what might be closer to like the core disease process that is happening here, you find some really interesting and tricky to get your head around stuff. Some really kind of fundamental disturbances in the fundamental building blocks of experience and of the way we experience the world and ourselves. So perplexity, we talked about this overwhelming sense of there's something odd going on, but I don't know what it is. Really hard to imagine, but this is, you often see in the prodrome of schizophrenia. And aberrantly salient experiences. So we talked about salience when something is important to you. Like if you walk past someone in the street and you don't know them, you just would forget about it a second later, hardly pay any attention. But you walk past someone in the street and there's someone you know, your attention is drawn to it and it feels important and you go up to them and talk to them. That's a salient experience as opposed to a non-salient one. And in the early forms of schizophrenia particularly, people will just, random mundane stuff will happen and it will feel like it has this important meaning that has real relevance to them and is vitally important, and sort of aberrantly salient experiences. And that seems to be one of the things that happens at the start of the disease process, that then maybe these delusional perceptions is a way of making sense of that. That black car outside felt so important to my safety. It must be because the police are trying to track me down and harm me, whatever it may be. And this all gets so trippy, but the sort of disruptions in what things mean in the world. You might see people with schizophrenia using kind of neologisms, the kind of made-up words, if you like, or using words that it obviously means something else to them than it does to other people. There's sort of this slight disassociation between what a word normally means and what it now means for them, and then, yeah. And obviously we talk about words, they're kind of the packets of meaning that we build our world out of in many ways, so something fundamental about that. And this just gets so hard to get your head around, so I will try my best. But this is, if you read any phenomenology, which is the study of subjective experience, they've looked a lot at this, and it's so interesting, but so complicated and mind-bending. But it's almost like you're having thoughts, but they don't feel like my thoughts anymore. There's something wrong with it. It doesn't feel like, you know, I mean, we take for granted that you have a sensation or a thought or whatever, and it just intuitively, it's yours, it's in your head. You don't even need to think about that normally, but there's a sense that actually that stops being intuitive, and thoughts that you're having stop actually feeling like your thoughts. It's very hard to imagine what that might be like at all. And there's this sense, as we talked about, your thoughts being taken out or put in, whatever, your body being controlled. There's the internal world. Sorry, that's actually the third point. Your internal world is being intruded into by some other, by the police or the neighbours or whatever it may be, some agency that's trying to harm you. Intruding into your mind or your body that normally we completely take for granted that we have complete control over that, nobody else can read our thoughts. And yet, so it's a very stark difference, I guess, from the normal human experiencing of the other intruding into the internal world. And equally, your internal world spilling out. So thought broadcasting, everyone around me can hear what I'm thinking, for instance. So yeah, this is very interesting, very hard to really imagine, but it's very often there underneath the more kind of barn door symptoms of schizophrenia. And maybe it gets a bit close to what is at the core, what has fundamentally gone wrong in schizophrenia, like what's the start of that process. But we don't fully understand it yet, needless to say. Anyway, I think a better illustration than all of this talking are these paintings. They are by a man called Brian Chandley. He was an artist who suffered with schizophrenia. He was stable on antipsychotic medication, and he decided, potentially inadvisably, but he decided to stop his medication and paint a self-portrait every day, documenting, if you like, how his world changed as he relapsed into his illness. So this was him on day one. And I should add, he wasn't saying, I looked in the mirror and this is what I saw. He was trying to portray, I guess, what it felt like to be him. So you can maybe see some of the things that we've talked about, these just formless sense that the world is not right. This massive ear, he can suddenly hear all of these things that he couldn't hear before. And then this shout on his forehead, his thoughts are being shouted out to the world and everyone can hear them. They're no longer safely confined in his head. Then these arrows coming in from all directions, being attacked from all sides, this general sense of I'm being fired at, that everything around me is trying to harm me. I mean, and here, further down, it becomes sort of monstrous, if you like, this monstrous perception of himself. And part of his psychosis was, part of his delusions was believing that he was responsible for a friend who died by suicide. So you can see him seeing himself as this kind of monstrous creature. And then later, even down the line, the image of himself dissolves completely to this web of things where you've got these enemies everywhere, and just it's very hard to make sense of it at all. And very sadly, I can't remember, if you go on brianchandley.com, I think there are many more pictures than this, but very sadly he died by suicide in sort of 60 days or something into this experiment, which is terribly sad. I mean, and he has left us this amazing portrait to point of what it might feel like to have schizophrenia. So I think probably that paints a better picture than any of the rest of the stuff I've talked about. So, from the sublime to the ridiculous, or rather mundane, let's open polling for a second knowledge check. Right, fire away, please. And I'll just quickly answer a few questions while you're doing that. If enough people believe in it, is it still a delusion? Oh boy, well, what a question. I mean, I cannot voice any political or religious opinions, obviously. I mean, political opinions is obviously what I'm thinking about. But I guess a delusion is a disease process in an individual, essentially. And you can talk a lot about what has happened to that individual to cause that process to come about. But if lots and lots of people believe it, it's unlikely that they're all psychotic. And also, if they were all psychotic, they'd probably all believe different things. So, and we've got 10 more, few more responses still to come in. Yeah, so if enough people believe it, it's still a delusion. I mean, if lots of people are believing it, it wasn't a delusion to start with, I guess. But in a psychiatric term. Difference between primary and secondary delusions, great question. So primary delusions have just appeared, this belief has just formed. They are just convinced that their neighbours are poisoning them. Secondary delusions, maybe they had voices saying lots of stuff, like saying that they're a bad person, saying that people are trying to harm you. And as a secondary result of that, they developed the belief that whatever, they're being attacked by some people. So it's secondary to another process. Anhedonia is a lack of pleasure in things. So you can't, and it's not just that, it's just a complete inability to feel positive emotion that we normally get when we do something we enjoy. And it's really hard to imagine. I mean, it's one of the cardinal features of depression, and you mainly see it described in that context. But people describe it like there's a thick glass wall just separating them from all the normal emotions that they might have. And it's something you can't perceive really until it's gone. It's very hard to, because we go through our day and loads of stuff happens and we just feel good about it or feel whatever. And to have that gone and just not feel anything when good stuff is happening is really hard to imagine. That's what anhedonia is. Ego dissolution would be, I guess, the dissolving of the ego. Light reading recommendations, schizophrenia, psychosis. Yes, The Shock of the Fall is a very good novel about someone with psychosis. The Shock of the Fall. I can't remember what it's called. I'll type it in the. I'm sure there are many others I haven't capitalized. Anyway, there we go. It's a good book, can recommend. Right, we've got all our answers in, I think mostly. So yes, wait, no, okay, interesting. So hang on, what's happening here? So oh right, I thought the orange one was, I'm just talking to myself. Right, okay, most of you have gone with intrusive thoughts. However, I'm afraid the positive symptom of schizophrenia on this list is thought withdrawal. That was one of the, this is quite a tricky question to be fair, thought withdrawal, which is the second most popular answer, because that was one of the delusions related to thought, that your thoughts are being taken away. Disorganized affect would be a disorganized symptom of schizophrenia. Social withdrawal is one of the negative symptoms, as is lack of motivation or apathy. And intrusive thoughts is not, so in psychiatry, I'll leave this for a lecture on OCD, but intrusive thoughts are actually nothing to do necessarily with psychosis or schizophrenia. They're a feature of OCD, which we don't have time to really talk about, though I'd love to. I'll do a talk on OCD some other time. Yeah, there we go. Well done for that. So, moving back on. Let's look quickly at the etiology. This is the last few bits. The etiology and treatment. So what causes psychosis or schizophrenia? And how do we manage it? Bit of neurobiology, because we love this. I'm sorry that so far it's all been very phenomenological, but I guess that's just what I find really interesting. And I think it's helpful to actually start by understanding what it's like for this person, because the neurobiology is all very well, but maybe it doesn't necessarily help you when you're in the room with someone that's experiencing this. So I always give precedence to that. But the neurobiology is great and interesting. I've only got one slide on it, sorry. But yeah, there's a significant genetic component, first thing to say, for schizophrenia. So it's about 80% heritable, so chunky. And compared to anxiety or depression, where it's about 40–50% heritability, OCD a bit more, sort of 60%. But yeah, it's there's a lot of genetics involved. It's not just genetic, but big part of it. And a prevalence of about 1%. And think about that. I'll come back to that in a couple of slides' time. But that's quite common for a disorder that has such a huge genetic component. So I'll leave that hanging. And it's not a single gene disorder, as you probably know. It's over 200 genes, many, many genes. Many of them, interestingly, that overlap with those of bipolar affective disorder. There's lots of interesting stuff you can read about that. This is a disorder that also can feature psychosis. So when you become manic, mania is one of the features of bipolar affective disorder. And that's a manic presentation, as I mentioned in that first slide about madness. And there are lots of different genes, lots of them related to dopamine, D2 particularly, which we'll talk about in a minute. Also neurodevelopment, so there's suggestions that it's a kind of a neurodevelopmental disorder, and it does tend to come on sort of between the ages of 18 and 35, but it actually seems to maybe has its roots a bit earlier than that, so that's interesting. And inflammation, interestingly, and I don't have much more to share on that, but there is lots and lots of theories about inflammation and schizophrenia, as well as actually some for inflammation and depression, and the kind of the role of the microglia, the cells in the brain that sort of are the immune cells, and how they change. Maybe we've overlooked that because we focused on the normal neurons. Anyway, that's very interesting. And the classic thing that you feature in exams, in psychosis, schizophrenia, there's excess of dopamine in the striatum. This part of the sort of the limbic system here, and it's particularly have an excessive response when you're under stress. And another interesting thing is there are abnormalities in the way the default mode network is functioning. You probably may not have encountered that before, but it's basically a network between areas of the sort of in areas of the frontal lobe and areas of the sort of occipital lobe that won't go into massive detail. It's a bit small print, it's more for your interest maybe, but these are the big, lots of theories about the key disease process of schizophrenia seems to involve the default mode network. And interestingly, if you look on an fMRI in someone who doesn't have schizophrenia, the default network seems to be responsible for sort of thought, self-reflection, the self maybe, kind of your sense of consciousness self. So it sort of makes sense in the context of all of those weird disturbances in your sense of self that happen in schizophrenia. But yeah, that's quite brief on that. But some particularly relevant things that I think are interesting. Firstly, the role of dopamine. I mean, it's the big one. Because dopamine is largely responsible for salience. It's all about directing our attention and our motivation towards stuff that's rewarding. You know, dopamine has a huge involvement in addiction, obviously. Spikes of dopamine, stuff you're addicted to, all of that. But it's also very, and kind of related to that, it's very responsible for salience. You have a kind of a dopamine activity when you have a salient experience. And this excess of striatal dopamine maybe makes some sense of the reported experiences of a random thing happened that actually wasn't very important, but it felt very, very important. There's this abnormal salience attached to stuff, which seems to be like an early feature of psychosis that maybe actually paves the way for lots of the other things that later on. And working memory is another interesting sort of process that's related to schizophrenia, and this is the enormous amount of just data that's stored kind of pre-consciously about the world. Just you know where you are and who you're talking to, whatever. You don't really need to think about it all because everything you've taken in over the past 7 minutes has been sort of stored, and actually allows us to contextualize and just have an inherent feeling that I know what's going on. So you can imagine if something goes wrong with working memory, that might lead to a pervasive feeling of I don't know what's going on, like perplexity. And also it sort of relates to thought disorder, where someone is just jumping from one topic to the next. There's this loosening of associations between things, and it's almost like there's a slight really short-term memory problem that, I mean, not that you could test or remember these 4 numbers, they might be able to do that fine perhaps, but there's a jumping from topic. So these are 2 sort of processes that are related to some of the experiences we've talked about already. And then in terms of the causes of psychosis, so there are quite a lot, and they're pretty the same, I guess, as the causes of schizophrenia. But yeah, I'll mention that as we go along. So what causes you to go in the mad box? Well, as we said, big genetic component, but I said it was very, very common. 1%, like 1 in 100 people. And this is across all of time and all of, as far as we know, throughout history and across the world, wherever you are, schizophrenia still is affects 1% of the population. And it is a catastrophically disruptive disease. If you have this disease, by and large, you will be cast out of whatever society you're in because you're mad, you're insane, you're scary, or whatever. So wherever you are in the world, wherever you are in history, probably if you get this illness, it's going to plummet your reproductive capacity, I would guess, because of this social, how much it would wreck things for you. It's a pretty bad illness. But it still occurs in 1% of the population, which is a lot. And so the only logical conclusion of this is that all of these 200 genes that predispose to schizophrenia, there must be big advantages to having those genes that outweigh this really quite likely, well, 1 in 100 is likely on a sort of global evolutionary epidemiological setting. There's quite likely chance of developing this catastrophic illness. And there are lots of theories about what those genes are useful for. Potentially language, creativity, you know, lots and lots of famous geniuses throughout history have also had psychotic illnesses. Vincent van Gogh, one of my faves, but many others. And yeah, and interestingly, to give an example, the baby picture, that was from an experiment done in Cambridge, a study done in Cambridge, where they took lots and lots of pictures like that, and they looked at people who had a high genetic load to schizophrenia. So they had a first-degree relative with a psychotic illness, and they tested their ability to see what the picture was before they'd seen like the photo that had been extracted from. And they had a lot of different, like the baby one is too difficult for anyone to guess, but others you could sort of work it out. And the people with a high genetic load for schizophrenia were better at making the leap to realizing what the picture meant, kind of filling in the gaps, which I guess you can imagine how valuable that skill is for humanity, to be able to jump to those conclusions that no one else can see. So, but we don't know what all of these genes are for, really. We know like little bits. Oh, this one codes for this protein. It's to do with inflammation. It's to do with, but the kind of global effect of what those genes are for, we don't really know. But there are hints that it's to do with that. And then developmental adversity is a big one. And I think we can sometimes think of schizophrenia as like this brain disease, like something's gone wrong in the mechanics of the brain and now you're crazy and that's it. But it's not really like that. There's much more social element than you might think. And people having histories of abuse, as we kind of mentioned as we go along, further back in the talk, will predispose you to having an illness like schizophrenia. And it sort of makes sense. If you might have internalized the idea that people around you are hostile because that was your experience growing up in a household where you were abused, for instance. I mean, you can kind of imagine. And just in terms of what developmental adversity does, it tends to sensitize the striatal dopaminergic system. It makes you have a bigger dopamine response to stressful situations, which obviously in worse settings is what we see in psychosis. Demographic factors really important as well, and you kind of need to know these as well. So living in an urban environment compared to rural increases your risk of having psychosis, and migration increases your risk of having psychosis. And I guess they can make a bit of sense, I suppose. It's such a, I mean, I'm fortunate enough to have lived, I'm living currently 2 minutes walk away from where I grew up, so I have not migrated in any way, but you can imagine, I suppose, having to leave where you grew up and move to a completely different place where the culture is unfamiliar. It's quite frightening, very unsettling, it feels maybe like your whole reality has changed, and I guess you can imagine how that might knock your reality processing a little bit for anybody. So it sort of makes a bit of sense in the general chaos of the urban environment, perhaps. But yeah, there's more to be said that I don't know about why these are specific factors. And then life stresses. So basically, like I said, the person at the beginning who swam across the Thames, they were already under lots of stress because of working in another country, far away from their family. Then it was lockdown, even more stressful. Then I think they had a really bad relationship breakdown. So all of this stress, and they became psychotic. And I'm not aware that they have a family history of psychosis, which is interesting. So, and the stress vulnerability model is, you've probably encountered it, like someone who's really vulnerable to start with has lots of these factors to begin with. Well, a lesser stress will be required to tip them into psychosis, or I mean, any illness that you're talking about. Whereas but actually anyone can develop psychosis when put under enough stress. Potentially, given their genetic makeup and their experiences, before they become psychotic, they might develop severe anxiety or depression or an eating disorder or something else. But yeah, that's the stress vulnerability model. But yeah, so typically episodes of psychosis are precipitated by an acute, really bad stressor. And then there is a relationship with recreational drugs. It's not a completely straightforward one. There's lots of very mixed and interesting evidence. I defer to the wonderful David Nutt, who is a great guy who has lots and lots to say about the relationship with recreational drugs and psychosis. If you ever get a chance to see him speak, go for it. He's really funny. But yeah, there is a relationship, particularly with, probably aware of cannabis, but particularly synthetic cannabinoids like skunk spice. There's a big chance of them causing psychotic illness, whereas actually many other drugs, not so much. But equally, it's a bit tricky, because if you're having some of these early, maybe you're already developing the disease process of schizophrenia and everything feels a bit odd, maybe you're having a few strange experiences, hallucinations that you can't quite make sense of. Actually, often something like cannabis will make that go away for a bit. And so you see someone who develops acute psychosis and they've been smoking cannabis lately, and there we go, that caused it. But actually, that was a sort of self-medication. It was the only thing they could do to stop those horrible experiences that they couldn't make sense of. So it's not a straightforward relationship. But about 25% of psychotic episodes that you see there'll be drugs there and are thought to be drug-induced. So yeah, be aware of that. So I hope we have unpacked the mad box and got a bit closer to the experience of this person who ultimately just has a slightly less solid grasp of reality than you do, but all of us have a slightly unproblematic and wobbly grasp of reality at the end of the day. So the idea that we think of them as completely other to ourselves, as mad, as insane, label them as completely different to us and we cannot relate to them anymore, is not really true. And I invite you, when you hopefully, eventually, if this lockdown ever ends, when you go on psychiatry rotations, to try and talk to these people and try and see where they're coming from and find out what their experience is. And then we said we talk about treatment. I know I'm running out of time, so I'm going to be very brief on this, and I said I would be. But basically, if antipsychotics, they're the medications. They are basically anti-dopamine. They're dopamine blockers, divided into two camps, typical or atypical, depending on their propensity to cause extrapyramidal side effects. So Parkinson's-like syndrome can be caused by these medications through their blockade of dopamine. And you remember Parkinson's is where those dopaminergic neurons in the substantia nigra die. So it makes sense that blocking dopamine might have a similar effect. Yeah, there's lots of them. You need to know quite a bit about them for med school, but I'm afraid I don't have time to talk about them today. But basically, they're very effective. Like, psychosis is really treatable. A chronic schizophrenia where someone's been really unwell for a really long time, you know, it's less likely. You can manage it and you can get them to a good baseline and hopefully stop them having further really bad relapses. But, you know, it's a chronic illness, it's a chronic relapsing, remitting illness, and you may not ever completely cure someone, but actually a single psychotic episode, your chances of getting better from that are about, your chances of, recovering from that, 2/3 roughly, they say, and then of that, people who get better from that episode and get completely back to normal, about 1/3 might have 1 or 2 other episodes in their life. And then the other 1/3 of people may, basically have ongoing grumbling psychotic problems and develop what looks more like schizophrenia. But there are also psychological therapies for schizophrenia, which I would love to talk more about. Fortunately, I don't have time, but have a read about avatar therapy. It's fascinating. It's to do with, I guess, giving someone a sense of agency over their voices, these voices that are constantly coming into their head and they can't control them at all or talk back to them, they're just there, and that's very distressing. They're often saying very horrible persecutory things, and avatar therapy is basically setting up a semi-immersive game-like environment where you can talk back to the voice suddenly, and it can have a massive impact on people's psychotic symptoms. And CBT for psychosis is very effective. It's a special type of cognitive behavioral therapy that's particularly geared up to psychosis. And both of these are needed to treat psychosis. By and large, in the acute setting, when someone comes in with psychosis, you're going to mainly do these to start with, to be fair. But they both have a role. Right, and a quick in the last couple of minutes before we go out for our clap, which of these statements is false? So I will open the poll, and I'll try and be quick. So respond quickly, or I'll give you 10 seconds if that's okay. We've got one so far. Cool. Okay, anyone else equals quickly? Sorry, I know I didn't give you time to read it. Yeah, which of these is false? Okay, I've had about 20 seconds. I'm afraid I'm going to cut it off now just because I don't want to keep you past 8. But well done. Most of you got it right, saying dopamine. And this is, I didn't strictly say this, to be fair, so this is a tricky one. But the dopamine is the only neurotransmitter involved in the disease process. It is actually not. There are lots of, as you might imagine, because the brain is pretty complicated. And actually antipsychotics, particularly the newer ones, work on a lot of different serotonergic, histaminergic, various other neurochemical systems. But dopamine is the most important. So if you think of one, think of dopamine. But yes, it's over 70% heritable because it's 80% heritable. And around 1/4 of psychotic episodes are related to drug use, as I said. And people who live in cities are more likely to develop psychosis. Cool. Right. And that is, I believe, there we go, the end. So here are the takeaway messages. I'll quickly whiz through them because then I want to go to the next slide. But yeah, the idea that perceiving reality is not completely straightforward actually for anyone. There are lots of different processes going on. If some of them go wrong, you might develop what looks like psychosis, be off legs in those terms. So it's a syndrome that often looks the same, but it's lots of different disease processes, can present in lots of different ways. And then, schizophrenia, essentially chronic psychosis with some particular features that mark it out. Multifactorial, as we know, dopamine, and it's readily treatable. So if someone comes in with a psychotic episode, it's pretty, early intervention is really key. And we have early intervention and psychosis teams to manage it. But getting in there early and trying to stop the psychotic disease process with appropriate medications, whatever it may be, try and take away all those stresses that are causing it, all of that. If you stop someone earlier on, they're much more likely to be in the third of people who never have another psychotic episode. So that's, whenever you're working in the future and you see someone who might be developing psychosis, act fast, is what I'd say, like within days. But yeah, I mean, within hours if there's actual acute risk. But yeah, there we go. This is the end. So please fire away on the chat with any questions while you, if I'd be very grateful if you could do some feedback for me so I can feed my ever-hungry portfolio and hopefully have a job at the end of quarter. I'm really sorry, I cannot see the chat, which is infuriating. Good. I don't know what's happening, but it's not letting me click on the chat. Oh, I don't know, Hinol, if you're there, if you could shout out some of the questions, but I'm afraid I cannot see them on the, it won't let me like open the chat to look at it for some reason because my laptop's stupid.
Yeah, sure, I don't mind.
Yeah, were there any questions that yet to be asked? Far away.
Yeah, there's some on the Q&A. So the
actually, I can open the Q&A.
Yeah, it's on the Q&A.
Oh, great. Okay, so if anyone has asked questions on the chat, please paste them into the Q&A and I'll answer them there. But I can't see the chat for some reason. Oh, so many good questions. Right, I'm aware people might have to go at 8. So if you have stuff to get to, that's cool. But I will carry on and answer these questions and stick around, please, if you can do. So what made me choose psychiatry over neurology? I mean, they're both really good. I suppose psychiatry, at the end of the day, in terms of the job that you're doing, it's very much more about the skill set that you develop, that you really hone and get to a level that is, I guess, above other doctors. You know, in the same way that a neurosurgeon gets really good at doing neurosurgery. In psychiatry, it's communication skills, and it's being able to walk into a room with someone who's incredibly distressed and talk to them, make them feel that they can talk to you, get their story, piece together from all of these fragmented bits of information, actually a coherent picture of what is the disease that's going on for this person, and be able to communicate to them, to be able to communicate that, because these are complex things, as I guess we spent a whole hour talking about one illness, like being able to make sense of all that complex information. And I guess that's what I love about psychiatry, that you really hone that ability and you become so, I haven't yet, I won't become a consultant maybe, but you become really good at it. Like you can see a liaison psychiatry consultant, for instance, walk into a ward where there's a patient on the surgical ward who's causing all sorts of problems because they have loads of mental health problems and it's all very difficult. And the surgeons are like, oh, I can't cope with this at all, and communicating ineffectively, and I say surgeons, I mean any medics, but and they can't make sense of what's going on for this person. It's all difficult. And a psychiatrist can walk in there and like sort it out in a way, you know, in the same way that if someone needed surgery, you'd want a surgeon there to do that. But that, I guess, is something that I wanted to be when I saw that in a hospital. So yeah, there's more of the person aspect of it. If you're interested in people's stories, in their experience, like why does this person have this particular delusion? Why didn't they get another different delusion? That's a cue that psychiatry might be for you. But yeah, and you learn about the workings of the brain a great deal in psychiatry. I suppose the reality is you use it less on a day-to-day basis. You need to know a lot about it, but you're not going to really bring it into the consultation very much, whereas obviously if you're doing neurology, you very much need to have that at the forefront of what you're doing all the time. But yeah, but so many other reasons I could say why I chose psychiatry. I could go on for hours, but I won't because I know you want to go away. Primary and secondary delusions, I hope I answered that already, I think. But shout if I didn't. Drug-induced psychosis. What quantity frequency of cannabis is someone likely to have smoked in order to get it? Great question. So I think you can smoke cannabis up to, I'm going to misquote the paper now, but I think it's up to like 4 times before the age of 18, and it doesn't increase your risk of psychosis by any noticeable amount. I mean, maybe it does a tiny bit, but not statistically significantly. So it's kind of more than that. So kind of any habitual use of cannabis is increasing your risk, and it's all about risk. And someone who has a big genetic load or predisposed sort of vulnerabilities only needs to smoke a little bit of it, or use other drugs. It's not just about cannabis. but whereas someone else could use it quite happily all the time for ages and not get any psychosis. Stress vulnerability model. How do you distinguish running commentary from thought disorders? So running commentary running commentary is a form of auditory verbal hallucination. So this is someone who is hearing someone giving a running commentary about what they're doing, as I said. So it's as if I was hearing a voice in my head right now saying, oh, now he's got his hand up, now he's put his hand back on the table, now he's looking over there. That's what a running commentary, auditory verbal hallucination is. So it's an experience that they're having. Thought disorder is where, if I was just saying, oh my, yeah, just saying words and I don't know, that's a very poor attempt to imitate thought disorder. It's quite a hard thing. I'll try and practice that. But someone who's just jumping from topic to topic to topic, for instance, that's a form of thought disorder. Or someone who just like stops in the middle of what they're saying. It's as if their flow of thought has just gone. That's a form of thought disorder. There are lots of different types, but it's a disorder in the flow of the way thoughts are working. Could you possibly go over delusion versus hallucination? Absolutely. So hallucination is an experience you're having. It's as if you are seeing or hearing, typically hearing something. So for you, it's a thing that you're hearing, a real voice, but it's not really there. And I mean, I think I put in inverted commas because I think it's important when you're talking to someone with psychosis to kind of not just say to them, yeah, it's not really there though, is it? Because for them, it's completely real. So if you're just telling them that part of their reality is no, you're not going to get a good relationship with them and you're not going to get them to answer your questions. So in another session about how to do a good mental state exam, I can talk more about that. But that's a hallucination, a thing in the world outside that you're perceiving that actually is not there. And then a delusion is this fixed, false, unshakable belief. So I believe that I'm just convinced that I am a multimillionaire and I should just go and give money to loads and loads of people. I should drive around all of the hospitals in the north of England and distribute money and food to everyone because I am a middle class. So it's a grandiose delusion. So it's not about perceiving something in terms of seeing or hearing it. It's about having this idea in your mind, very fixed and unshakable. Folie à deux. Folie à trois, I've never heard of, but I'm sure, I guess it's logically a thing. Folie à deux is basically French word. This is where you have two people who both seem to have the same delusion. And typically this will be usually in an intimate relationship, maybe a husband and wife, where one of them has a psychotic illness and is very convinced, has a delusion, has a persistent delusion. And the other person comes to be convinced of it as well. And you could argue that the other person actually isn't, well, yeah, I mean, it's better that the other person isn't psychotic. They're developing that belief is in the context of basically being told that it's true and being convinced that it's true by another person. So they have actually formed that belief in the normal way of forming beliefs, as if someone else came into my house and spent ages convincing me that, so I'm just about to say some terrible political commentary, but whatever, changed my beliefs about something. That wouldn't be a delusion, but yes, that's folie à deux when two people have the same delusion, but usually one of them has psychosis and the other one doesn't. Could we have your email? Yes. My email, if you, I'll just type it in the chat. Oh, the chat's appeared now. That is my email, tom.dalton1@nhs.net. Please drop me an email or get in touch via the Becoming a Doctor team. Feel free to ask any other question. Oh, really interested in a possible career in psychiatry. I only just read that. Great. Yes, please email me. Psychedelic research revealed about schizophrenia. I don't know off the top of my head. There is interesting research happening about psychedelics, particularly their therapeutic use in depression. But I don't know. I mean, sure there is some. I'm afraid I've not encountered it, what the psychedelic research about schizophrenia. But it's obviously there are related themes there, so I'm sure it's there. Sorry that I can't answer that one. Just to clarify, there aren't a fixed number or patterns of symptoms you need to diagnose schizophrenia. You need, oh, it's all very woolly, and I don't have the ICD-10 in front of me. So you need to have psychosis. You need to have delusions and or hallucinations, basically. And for it to be schizophrenia, it kind of has to be chronic. So initially someone might come in, you diagnose them with non-organic psychosis, not otherwise specified. So non-organic because it's not just caused by their Cushing's or whatever. It's a psychotic process. And then they might get diagnosed with schizophrenia later down the line. But as a working psychiatrist, I don't use those diagnostic criteria super often, because actually very often it's a thing that you recognize through just the whole pattern of everything that's happened to this person. I can see that this is schizophrenia, maybe because it has some of these features of the Schneiderian first rank disease, or for instance. So it becomes much more holistic and kind of more like an art, in the ways that, you know, any medic or consultant, it's not really about ticking boxes to diagnose heart failure. It's just the whole picture that you see it and you know what it is. But yeah, there is a more structured diagnostic criteria that you'll find in the ICD-10. I don't have it in front of me, otherwise I'd read it out. Sorry, but yes. Antipsychotics more effective than treating psychosis than antidepressants are at treating depression. I don't know off the top of my head. My gut feeling, or based on what I do know, is yes, they are. But I guess, yeah, antipsychotics have such a key role in the early stages of the disease. The first thing you do is try and block that whatever haywire dopaminergic system is going, and you can treat someone quite quickly. And then you need the psychological approaches as well to kind of maintain stability, to carry on the recovery process. But they're so important in the early disease process. Whereas actually for depression, what you need in the early stages is not antidepressants. Really, the evidence are that they don't help very much from mild to moderate depression. What you need is CBT, for instance, psychological intervention. And then the antidepressants have a very important role, particularly for people with moderate or severe depression, in helping, in enabling someone to engage in CBT if actually they're too severely affected by the symptoms to be able to engage in it to start with, to maintain stability once they've recovered, all sorts of things. I guess the way they're used is quite different, so it's a difficult question to answer. But yeah, sorry. I'm answering these in quite a woolly way. Difference between a syndrome and a disease. So a disease, I mean, as I understand it, a disease is like, it's a specific disease process, like a heart attack that's caused by a thrombic embolus, whatever, you know, some specific nameable thing has gone wrong, and you can make sense of that disease process and why it produces the symptoms that it does. Whereas a syndrome describes a constellation of symptoms, and it doesn't necessarily describe or indicate a particular pathology underlying it. So yeah, like, I guess I'm using the analogy, I would guess it'd be fair to say, no, I don't know. Yeah, I mean, to give these examples, so psychosis is a syndrome because if you have psychosis, you're labeling someone with psychosis because of this constellation of symptoms that they have. You're like, I know what this is, it's psychosis because it looks like this. But you're not necessarily saying what's caused the psychosis. So that's kind of the difference. But maybe there's a better definition of that, I don't know. Is alcohol included in the relationship with schizophrenia with recreational drugs? So you can get alcohol-related psychotic disorders. They're not uncommon because alcoholism is such a massive common problem in society. So it's probably something that you'll see, but by and large doesn't tend to cause kind of schizophrenia. Like, it tends to cause a slightly different picture of sort of, an alcoholic. You have all sorts of things with like chronic drinking that's like, it's sort of a dementia-like picture and various other things, and there's usually depression is what you tend to get, and you can get some psychotic features in there, but you maybe don't tend to get schizophrenia per se. But then often you'll see someone with schizophrenia and there'll be a long history of drugs plus alcohol plus other things, and it's a complex, and alcohol is undoubtedly chipped in a little bit in some way. Would it be correct to say that all dissociative disorders are caused by an acute severe stressful event, or is that oversimplification? So dissociative disorders are a different group of disorders. They include dissociative seizures, so non-epileptic seizure-like episodes. They include dissociative fugue or amnesia, where someone just loses a patch of time, dissociate, if you like, from reality for a short patch of time. They include functional neurological symptoms, where someone has movement or a paralysis that's not caused by an identifiable sort of tissue damage or nerve damage or anything. It's a dissociative symptom. The reason why it's called the dissociative symptom is quite complex, and I don't have time to go into it today. But yeah, dissociative symptoms are usually caused by, very commonly caused by trauma, particularly early in life. So they're kind of different to psychotic disorders. And yeah, very often they're caused by an acute stressful event. But yeah, that's a whole other talk, I guess. So I'll just quickly get to the end of the question so you can all go home. Obviously, you're already at home. What is the difference between primary and secondary delusions? Oh, okay, cool. Obviously, I didn't answer that quite well enough. So primary delusion, the delusion is sort of the first thing that happens, if you like. Well, not necessarily the first thing, but nothing else has caused that delusion to happen. It just suddenly the person is convinced that they are God, or they are a multimillionaire, or that their neighbours are poisoning them, whatever it may be. And there's no reason that you can see why they would think that in terms of evidence, in terms of experiences that they have had. It's just, they've just suddenly become convinced that that's the truth. Whereas a secondary delusion is formed secondary to other things. So they've been having voices for some time telling them that people are trying to harm you. And then as a result of that, the way they make sense of that experience, kind of as anyone would if you were having that experience, is to become convinced that, yeah, people are trying to harm you, but a particular group of people is trying to harm you, whatever it may be. So that's a secondary delusion. Where's the email? The email is in the chat. I'll just also type it in answer to that question. I'll copy paste it. There we go. Okay. Oh, bother. I think so if you want to just write it down. Oh, okay. Okay, I think the email's been posted. Right, good. That's all the questions. Lovely. Email me if you have any more. Hope to see you again on another of these. I'm sorry we've overrun. But yeah, I'm sorry you've missed the clap. I will see you soon. All right, Hanul, I'm ready to, I'll just stop sharing.